That's okay. So welcome to the Tees Valley CCG Primary Care Commissioning Committee meeting. This is a business meeting of the CCG and it's held in public so that those members of public who have been able to join us today, and I think we've certainly got one, I can see one, I think there's somebody else joining us as well. So thank you very much for choosing to come along today. Because of the restrictions, obviously we're holding this meeting on Zoom rather than at our usual venue. The meeting will be recorded and be made available publicly. So hope everybody's okay with that. To allow for the smooth running of the meeting, if you can put your mobile phones on silent, please. If you can you use the official background? I think I've failed miserably on that, I'm afraid. But if you are able to, if you can use the official background, to minimise background noise, if you can stay on mute unless you wish to speak, and remember to put yourself back on mute when finished. If you can raise your hand, it's okay now, mind you, because I've got my system set up better. Before I used to have to scroll across the screen to see who was putting the hand up, but I can see all on one screen now. So if you can raise your hand with the official button, please do so. If not, just give us a wave and I should be able to pick you up. And then if you need to leave your seat, can you turn your camera off until you return? So with that, if I experience any technical issues, Michelle will take over from me. We've got two members of the public, so I'll make sure that we go around and everybody can introduce themselves so everybody knows who's who. So I'll make a start and then I'll go around my screen if that's okay and ask people to introduce themselves. So I'm Caroline Gitcham and I'm a lay member and I'm chair of this committee. Jane?
My name's Jane Smales and I'm the corporate support for the meeting.
Lovely. Emma?
I'm Emma Joyer, I'm a commissioning lead for primary care for the CCG.
Thanks, Emma. David? Emerton? Sorry. Oh, I think David's frozen. Oh, is he there? Where's he gone? No, we'll go to Robert.
Yes, Robert Upshaw. I'm representing Health Watch Darlington.
Lovely, welcome, Robert. Karen?
Good afternoon, I'm Karen Hawkins. I'm the Director of Primary and Community Care for the CCG.
Smashing, thanks, Karen. Sue?
Hi,
Oh, you will have to get that mic sorted, Sue, if you present reports. Michelle?
Hi, I'm Michelle Thompson and I'm the Tees Valley CCG lay member for patient and public involvement.
Smashing. Mark?
Hi, Mark Pickering, Chief Finance Officer for the CCG.
Lovely. Nick?
Hi, I'm Nick Timman. I'm a GP in Hartlepool and Executive GP for the CCG.
Lovely. David?
Hi there, I'm David Emerson, Secondary Care Doctor on the governing body of the CCG.
Lovely. Smashing, David. And the other David? Oh, I've lost him.
He's just put a message up to say that he's lost connection, so he's going to have to log out and log back in again, Caroline.
No bother. Graham?
Hi there, yes, I'm Graham Earl. I'm the Digital and Estates Lead for the CCG.
Lovely. Becky?
Hi, Becky Warden, Primary Care Commissioner Lead for the CCG.
Smashing. Esther?
Hi, Esther Miracle, Consultant in Public Health for South East.
Lovely. Councillor Kevin Nicholson?
Hi, yes, I'm Kevin Nicholson. I'm the Cabinet Member with responsibility for health and housing in Darlington.
Oh, lovely. Welcome, Kevin. Welcome. Janet?
Hi, I'm Janet Walker. I'm a GP and I'm Medical Director of Tees Valley CCG.
Lovely. Janice? Oh, I've lost Janice. Hannah?
Hi, I'm Hannah Heron. I'm Senior Finance Manager covering Delegated Primary Care.
Lovely. And Nick, would you like to introduce yourself, please?
Hi, I'm one of the members of the public joining today. I'm Nick Marco. I'm the local democracy reporter based at the Hartlepool Mail.
Lovely. Thank you for joining us, Nick. I can see Sarah.
Yeah, Sarah Corrigan, Health Watch South Tees.
Hi, Sarah, welcome. And Janice.
Apologies, I lost connection. I'm
It's
Janice
okay.
Foster, I'm Chief Exec Cleveland Local Medical Committee, representing all the practices across Tees, except Darlington.
Lovely, thank you very much. So I think we had a lady that was expected to join us, but she hasn't come on yet. So if she does, I'll get her to introduce herself, but I won't go around the doors again. So thank you very much for that. There will be an opportunity, Nick, at the end of the meeting to ask any questions. Ideally, if you've got any, they should be submitted in writing beforehand. But don't worry about if you've still got any. We'll do our best to be able to answer them. So let's have a look. We've done the introductions. We've got some apologies for absence. We've got Jean, apologies from Jean Golightly. We've got apologies from Chris Black and Kulvi Federici from NHSI, sorry, NHSEI. We've got apologies from Lisa from Health Watch, but I understand that's why Sarah's joined us. And we've got apologies from Peter Smith from Health Watch Stockton. So that's all the apologies, isn't it, Jane? Yeah, lovely. So we are quorate. We've confirmed that we're quorate. So is there any items of any other business that anybody wants to notify me of? No, no, lovely. So if we can get straight into the business then, any declarations of interest in addition to the ones that have been attached? No. In terms of the item 7, the primary care budgets, GPs on the committee will have an interest in the related contract and budget values for primary care, but they're based on national agreements anyway. So there's no action required to manage that interest. The information summarised in the paper is based on national contractual agreements, which have already been confirmed, and there's no decisions required from the committee. So haven't got any other declarations of interest. So with that, if we can go to the minutes of the last meeting, which was held back in February. That seems a long time ago, that, doesn't it? They're on page 6. Are people happy to confirm that those minutes are a true record? Yeah, lots of nods there, lovely. And in terms of matters arising on the action log, I think though there was one item, but that was complete. So we okay with that? Yeah, okay, smashing. So if we go on to item 6, and that is Sue, and Sue's going to take us through the COVID-19 response and the restoration and recovery plan, and you need to be at page 19 on your papers. So over to you, Sue. Good luck with that microphone.
No, Chair, we can't hear Sue at all now. So I think what I'll do is I'll pick up in the absence of Sue's microphone. We're having a few technical difficulties this afternoon, I think, with a number of areas. So I'll pick up to make sure that the committee can hear the reports and also be able to comment and respond to those. So in terms of the paper that's been presented to committee, all we're asking committee today is to note the content of the paper, but to ratify the continued closure of the branch surgeries. There's 5 branch surgeries outlined in 2.1. The flexibility that's offered in relation to extended hours in Q1, and the suspension again of the LIS, and that's our local improvement scheme that we have in place as outlined in 2.2 of the papers. Committee members will be reminded that the committee did delegate to myself as the Director of Primary Care to ensure that we were able to enable our response to COVID throughout the period whilst we were concentrating on not only the vaccination programme, but some of the constraints that practices had at the time in relation to workforce. So the paper is to update the committee on the primary care response to COVID following the last report that we presented back in December, and also to request that the committee again ratifies those areas. So we've updated in 2.1 the branch closures that are included, the 5 branches that have been closed since the beginning of COVID, but we're asking ratification of continued closure. You'll see in the updates that there are some changes. So for example, in Park and Thorntree, the branch site is now open and it's being used by Thorntree patients because the Thorntree site has now been designated to provide COVID vaccination, and that's a COVID vaccination site for the PCN. Again, with the Linthorpe branch, although it was closed, it is now open and it's being used again as a designated site to continue to deliver the COVID vaccination programme, as is the Riverside Medical Practice. And the difference with the Riverside Medical Practice is that it is a temporary change in terms of the use again for COVID vaccination. So the Mackenzie Group branch practice at Hartfield's continued closure for the branch was to be reviewed. We're advising that that continues as we're unable to ensure a COVID safe environment for patients and staff. And we would expect that once we will reassess that following the national publications and announcements in June in relation to our COVID response. And the Zetland Medical Practice, we are looking to continue for that closure of the branch site until they are able to also implement a COVID safe environment. Again, waiting on information nationally or as to what our response will be expected on the 21st of June. We have, since the inception of COVID, we've been freeing up practices to support not only the COVID vaccination programme, but to support the implementation of new working practices. So you'll be minded as a committee that we agreed around extended hours. Extended hours are required to be delivered outside of core hours. We offered flexibility in the provision of that arrangement to make sure that practices were able to provide additional hours. So we didn't lose the hours that were available, but they were able to move those into core hours to help support delivery of the vaccination programme and that additional capacity that may be required because patient access did change throughout the pandemic to be able to deliver additional access for patients during the COVID response. And then also we have our local incentive scheme. We suspended our local incentive scheme with the exception of the clinical elements of that scheme to make sure that that practices were being freed up to address any backlog and also freed up to support the COVID vaccination programme. So we again agreed to extend that through Q1, and that will continue to be reviewed, and subsequently a paper will be brought back to committee in terms of our next stage response. So no other delegated commissioning decisions have been made since the last committee, other than those that are outlined as in the paper. COVID oximetry at home, although the referral criteria has now been changed to include patients aged 50 and over, in line with the national picture, activity is being monitored through the COVID oximetry at home project board, and Dr. Janet Walker is responsible and oversees the implementation of that. The hot and cold clinics, the GP Improved Access Scheme does continue, and we have repurposed the hot and cold clinics to continue to support primary care in response to those patients who may be COVID positive attending a designated site. We are continuing with that currently, but on the understanding that on the impact of the vaccination programme, if that continues, that we expect our clinical capacity to reduce and the cold clinic capacity to increase, which will ensure support during the recovery phase and to address any backlogs. So the recommendation for committee is to note the content of the paper and to ratify the decisions that were made outside of committee in relation to the closure, the extended hours and the suspension of the LIS.
Brilliant. Thank you very much, Karen. That was excellent. Has anybody got any questions or observations for Karen? No, I think all of that was pretty straightforward. So are we happy to, we're being asked to note the content of the paper and ratify the things that Karen set out. Are we happy to do that? Yeah, lots of nods, smashing. That's great. And then are you able to take us through the restoration and recovery plan, Karen?
Yeah, of course, Chair. So in relation to the restoration and recovery plan, what we've tried to do, because we know for committee and for ourselves, there's lots of documents that are now available in relation to primary care and primary care recovery. So what we've tried to do is make sure that we distill that into an easy read document. It sets out what our vision is in relation to recovery and restoration of primary care, and it's nothing that you wouldn't expect. So to make sure that any positive work that's been undertaken during the pandemic is built upon during the restoration and recovery phase, we need to be able to continue to drive transformation at pace to continue to deliver high quality, clinically sustainable services. We need to ensure our focus is on addressing the backlog, and any backlog, we need to ensure that we're improving outcomes for our populations and having a population perspective and driving down health inequalities. And we need to ensure that we have a clear focus on the most vulnerable. So we've tried to distill that vision so it's easier to read, but also just be mindful that this isn't a vision and this isn't something that can be delivered in isolation within a CCG or within primary care. It absolutely requires a whole systems response in relation to population health management and addressing inequalities. So we'll be working very closely with our directors of public health within our local authority areas, linked to our health and wellbeing plans and linked to our joint strategic needs assessment to ensure that we continue to focus from a systems perspective and not forgetting really importantly, our voluntary sector and the contribution that the voluntary sector have made through the pandemic period. So what we've tried to do is we've tried to outline in 3 areas, and it was very difficult to try and break it down into 3 areas in terms of how our approach will be. So absolutely around access, making sure it is around access to high quality and effective care through primary care, making sure that we're able to manage any future surge pressures. We have to be mindful, although the vaccination programme has commenced and is being delivered, that we still have to ensure social distancing. COVID is still here. We're still dealing with a pandemic. So we need to make sure that if there are any future surges in pressures in primary care, that we're able to address that. So it's really clear that we need to reinstate general practice services that were suspended. So quality and outcomes framework and some of our local arrangements were suspended. We need to be focusing on long-term conditions and ensuring that we're continuing some of the elements that have been really successful through this period in helping support primary care, but also manage patients with oximetry at home support and the long COVID clinics that are now available. We need to be building on the successes and learning from our vaccination programme to ensure that practices are prepared to deliver a COVID-19 booster programme, should that be announced, and also that we're able to look at how we embed and we work with practices again across the system. So we've also built in around capturing and building on the innovations. Now, the pandemic itself, although it has been really difficult, it has created innovation across the whole system. Our digital programme, and you'll see there is a digital report, the digital rollout has been progressed at pace. We need to be able to ensure that there's shared learning and best practice across primary care networks. Bearing in mind, primary care networks are groups of practices working together. So working in a very different way to they have historically. So we need to make sure that they're able to share learning and best practice in terms of what they've learned through the pandemic process, and we'll be facilitating some of that and making sure that our digital and estate strategies are able to be developed further to make sure that that not only supports the recovery approach, but supports the transformation as we move forward. So there's a number of areas within our building on our success and innovations through the programme, but most importantly, it's around our focus on population health at place and making sure that it's based on our health and care needs for our populations and focusing on the most vulnerable. So building on the work that was already undertaken nationally around the network directed enhanced service, so that's the primary care network, groups of practices working especially to look at early cancer diagnosis, structured medication reviews, and making sure that we continue to work with the practices and with our multidisciplinary teams across both community and health and social care to make sure that our enhanced health and care home model is delivered. Again, sharing best practice across the networks and making sure that we recommence the focus that was on population health and looking at our health inequalities at a local level and making sure that we're able to support that through the use of data as it becomes available. So that's just a whistle-stop tour of lots of the work that's happening, but we thought it would be helpful for committee to see that in a more distilled one-page product. Obviously, there's lots of detail that sits behind all of this and work plans that sit behind of this to be able to make sure we're able to take that forward.
Brilliant, Karen. Thank you very much for that. I didn't know whether any of our local authority or Health Watch colleagues had any particular observations, because as Karen said, obviously it's a whole system approach. One of the things I wondered, Karen, is in terms of the opportunity to consult with stakeholders and the public engagement piece, because I really like this document. I thought it shifts us from one place to another, and it quite succinctly outlines all of the things that need to be done to get into that next phase. So I just wondered what the plans are in terms of the opportunity for people to comment.
Yeah, so as we move forward in relation to our recovery, and particularly around that transformational work, it's really important that we seek views from the public and from patients and wider stakeholders. So we're liaising with our engagement teams to ensure that we're able to do that safely. That hasn't commenced as yet, obviously due to dealing with the pandemic and COVID, but it's not to be forgotten at all. It is really important that we continue to engage, and we'll be able to bring an engagement plan at a future meeting in relation to our recovery programme, because it's not only primary care. Recognising this is a primary care committee, we've brought the primary care element of recovery, but there's a much wider piece that's happening across the whole of the CCG, working with our partners and our providers to pull a recovery plan together across our local area and at a strategic level across the ICS. So we will be able to bring an update back to committee in relation to the overarching programme in which primary care sits as an element of.
Smashing, that's great. Janet, I can see you've got your hand up.
I think David might have been first, Caroline, but
Sorry, David. Sorry, I didn't. You've got your hand is on your wardrobe. It's merged into your wardrobe.
Oh, apologies for that. Yes.
Sorry, David.
Yes,
You go
yes,
first.
thanks. Firstly, apologies if this has been answered. I lost my actual internet connection twice when Karen was speaking, so I lost some of what is. Two things. Firstly, about moving forward and being assured we can continue the oximetry at home. Is it our responsibility as the CCG to actually have a stock of the pulse oximeters in case they are needed either in the winter or a future epidemic, or is there a sort of a central reserve which would be made available? That was the first question. And the second one is relating to the third column, really, about population health moving forward. We've been told a lot over the years about the so-called lifestyle issues of smoking, alcohol, and diet, and the issues they have on population health. And although smoking is less than it was, the others are still real issues. And I'm just wondering, for moving forward, how do we see the resources for progressing these the public health type issues from the point of view of primary care's responsibilities?
So in terms of, I'll answer your second question first, David.
Yes.
And that's because I'm going to swiftly move the first question across to Janet, and I could see she was waving to be able to respond to that around oximetry at home. So in terms of the population health, I think that's why I made it really clear that we can't do this in isolation of our wider partners. We have to absolutely work with our, not only our providers, but most importantly, our directors of public health. And we need to engage with them to ensure that we join it up across the system, because there are elements that will be commissioned from a public health perspective but delivered by primary care, and there will be elements that are commissioned for primary care and delivered by primary care or community. So we need to bring it all together, and we need to look at our inequity plan as to how we're going to address that and which areas we're going to focus on. But a lot of that needs to be driven by the data. It absolutely needs to be driven by fact, so that we're focusing in the right areas and we're looking at our populations. So we won't be doing that in isolation. And again, that's something that we'll need to bring back as part of our wider recovery plan around how we address health inequalities and how we work as a system to do that. Just to offer you some reassurance, the directors of public health have they've already been in contact with us in relation to recovery and how we make sure that we join it up across the system. So we will be working with them to do that.
Thank
And
you.
I'll pass to Janet for the oximetry question.
Yeah, Caroline, if that's okay, I can reassure members that we have a very healthy supply of pulse oximeters for use by the COVID oximetry at home service, and they have been nationally acquired and nationally supplied. So we are in receipt of those and can order further should we need to do so. Patients are encouraged to return the pulse oximeters. Now I have to say, yeah, we haven't got 100% return. The population of Teesside maybe see the value for other uses. So, but that is an ongoing part of the COVID oximetry at home, trying to get them returned back as well. But there are plenty more that we can access should we require to do so.
Brilliant, thanks Janet. And then Robert, you were next, and then I can see that Janice and Esther have got the hands up, but if you go next, Robert.
Yes, I'd just like to say that as well as Health Watch, I'm on the Governing Council of the County Durham and Darlington Foundation Trust. And we're being assured that, although obviously waiting lists are pretty much at record levels at the moment, they've more or less stood up all of their operating lists, and they're rapidly hoping to get back to normal operations. And that clearly will take some of the pressure off primary care.
Smashing. Yeah, thanks for sharing that, Robert. That's good to hear. Janice.
Yeah, I just wanted to basically, firstly, thank the CCG in terms of the report. I agree, it's really helpful having it all as a page to review. And I think it's to be commended in terms of the flexibility that's been taken and the pragmatism that's been taken, that's allowed us as an area to deliver the services and get services stepped back up again as well for patients. And I think we do need to look at the positives, but one of the things to comment on is we're talking very much about the positives moving forward and taking, if we can call it positives from the pandemic, but that type of work going forward. I think what we also need to remember and not lose is some of the good work that was taking place before that, some of the prevention work, etc., and make sure that we build that in. And also some of the work by way of work that we've been able to let go of and changes in the system that actually to revert back to old ways of working or to see those behaviours slip back in would be detrimental. We've made some real leaps forward. So it's recognising those things we do want to reinstate and not lose sight of from the old working, but also those that we can actually continue to let go and move on in the new world. I also wanted to comment on the way that all of the ICP, so across the whole of the Tees Valley, the way the system has worked together, as Karen mentioned, and it has been a whole system approach. And I think it's really, really important that we don't let go of that and that we keep that in place, because the system has worked together very, very well. And I think to keep that integration and that tighter way of working and communication is absolutely key. The final thing that I wanted to pick up in it is around the workforce. And I don't just mean primary care workforce in this, I mean all the wonderful volunteers who we've had and the organisations that have stepped up to help with the COVID response, vaccination programmes and things. And I think anything that we're looking at, we need to look at that in consideration for the exhausted workforce we've got and the volunteer workforce who will eventually need to go back to their daily living and their day jobs or whatever else they have in life, and how we're going to manage that transition as well, because there is quite a transition for workforce as well to take place. So I think it's just making sure we reflect that in there, because it's not a hard and fast numbers that would appear in terms of we've put in this as a way of working, but rather it's a recognition of all the things that volunteers and primary care staff amongst others have done.
Brilliant, thanks for all of that, Janice. Esther?
Thanks, Caroline. I just wanted to re-echo what Karen said about the joint working and the partnership working on the population health. And just to mention that not just in South Tees, but across Tees Valley, the whole public health system are ready and willing to work with our partners on that agenda. But it's not even just that third priority only, or the other two priority areas as well. We'll be more than happy to work in partnership with yourselves. And just to re-echo as well, to say, I mean, as part of the learning that we've gone throughout the pandemic, I've seen very great partnership working amongst ourselves. And I think we would be more than happy to be working along with primary care on those agenda. And Karen, thank you for putting a page, you know, on a plan on a page. I always say page on a plan, you know, a plan on a page with such a massive agenda. It makes it so simple and easy to understand exactly the direction of travel. So thank you for that.
That's fair. Thank you very much, Esther. Janet, is that an old hand or a new one?
It was a hand from before, Caroline, if I may. And I don't want to dampen any of the positives that people have been talking about, because absolutely there are so many good things that we need to carry on with and carry on going forward. And it's great to see on a plan on a page, but by gum, that's, forgive me, one hell of a plan. And I wouldn't be doing due service to our practices if I didn't acknowledge that there are a lot of challenges in us delivering this. Understandably, yes, you know, we need to work very much as a collaborative across the Tees Valley, because yes, for us to improve the health of the population, we've all got to play our part and play our role, and that includes patients feeling empowered to look after their own health as well. But it has to be commented that yes, practices, you know, have been working very hard and diligently during the pandemic and will continue to do so. But there are significant challenges with managing to address the backlog, as well as doing the day job, because people will continue to have new conditions presenting all the time, just as they would normally, as well as dealing with the backlog. And we just need to be cognizant of the challenges ahead of us, which are significant. I think it has to be raised.
Yeah, no, great points, Janet. Karen, do you want to come back with anything in terms of all of those comments and observations? Oh, you're on mute. No.
Can you hear me now?
We can now, yes.
That's very strange. I wasn't on mute and very strange. So I think it's great that we've got that whole systems approach to how we address things. I think, as Janet said, we can't underestimate the task ahead of us. And I think that's where the learning from this past year around working together has been so important, and that we make sure that as a system, that primary care doesn't become the shock absorber for the rest of the system, and that it absolutely is about a whole systems approach. And we'll just continue in that vein, recognizing this is, you know, Rome wasn't built in a day. It's not going to happen overnight. But as we work through the rest of this year, we'll make sure, whilst we're collaborating, that we're continuing to deliver that high quality care for patients. And that's the most important thing.
Brilliant. Thanks very much, Karen. Janice, have you just popped your hand up there? Yeah.
Apologies. It's just something that came to my head as Karen was saying her little bit there was, is there a similar plan on a page for the other elements of the system? Because obviously this is a primary care plan on the page, because it'd be really good to see how they all dovetail together, and then we can actually build on that jointly.
So that's the work that's being done through the ICP group, Janice. So that is in progress currently. Obviously, there's a lot more, as you know, being the LMC.
Oh, your mic's gone off again, Karen. Can other people hear Karen, or is it? No, nobody can hear you. I wonder if you take your back, people have said if you take your background off.
Can you hear me now?
Yes, yeah.
I have no idea what's going on because I'm not on mute. It's Zoom. Sorry about that. I don't know where I got to, so I'll say it again. So apologies if I'm being repetitive. The primary care elements that are pulled into the plan, a lot of those were nationally identified and set through the contract discussions in the contract letter that came out. There is work that's happening across the ICP, so through the ICP Recovery Planning Group, to bring all of this together. One of the things that we wanted to ensure is that partners were cited on what the plan was for primary care, so that that could be considered in terms of the recovery plan from an elective and an acute perspective, because of the size of the ask in primary care, so that they were cited on that initially, and that there was no assumptions made from a primary care perspective, and primary care becoming the shock absorber for the rest of the system. So I hope that helps, but there will be additional plans.
Brilliant, thanks. And Dave, you've got your hand up.
Yes, no, yeah, just fighting with the mute button as well. Apologies on some gremlins this afternoon. Yeah, just to reinforce a bit, because it's a really good question, Janice, a really good comment. We talk a lot about integration and integration, this and integration that. Actually, for me, this is integration. So if we get that collective plan of all the constituent parts, but it's only ever going to be delivered together in one. So if we can come up with a succinct plan on the page as this with so much detail in it, which is the challenge, we'll do it for the whole system, because I'm really heartened by the comments from partners around the table that, you know, we are in this together. We'll do this together, and therefore if we can have some sort of plan to share, especially your earlier question, Karen, with the public about this is what we're about, would be really helpful. So yeah, I'm really heartened by this huge challenge, but you know, we need to crack this one.
Brilliant. Thanks very much. I'm going to, lots of great discussion there. So Karen, what's the ask of the committee? Because on my papers, I've just got that as a page, but I think it's part of the previous report. Do you just want us to note and ratify that? Yeah. We have got some gremlins, haven't we, this afternoon? Just
Sorry, I have no idea what's going on today. Can you hear me now?
We can, yes, yeah. So you
Yes,
just
so
want
it
us to ratify that, yes?
Please, and that you agree it's a direction of travel. Yeah.
Yeah, everybody okay with that? Yeah, lots of
yes.
Lots of nods, lovely. That's absolutely smashing. So the next item is item 7, and we're up to page 26 now if you're scrolling through your papers, and that's the primary care budgets, and Hannah's going to take us through those. Over to you, Hannah.
Thank you, Caroline. I'm a little bit nervous going forward with the IT issues that we're having today. So this is a report for the Tees Valley CCG primary care delegated budgets and the position of those budgets at the end of February, which was month 11 of 2021. I'll go down. There is no major changes from, or have been no major changes from the last report that we brought. So I thought I'll just summarise really going down the forecast outturn column, which is on the right. Where we think we're going to be landing for the end of the year. The bottom line, we are currently showing just short of £1 million surplus. So, and most of that being made up of 1920 prior year accruals that haven't been needed or haven't been utilised, and then being a benefit into the 2021 position. I suppose the major variances that we've seen through the year have been around QOF. We've had additional points on QOF last year, not many, but a few. And also we've had an awful lot of potential income protection around QOF. So we've seen an increase. We've made sure that we've got enough coverage on the QOF line to cover all of those different elements that are going on. We've also got, go on.
Sorry, I was just going to say QOF for Nick's benefit, in case he wonders what we're talking about.
Quality outcomes framework. So yeah, we have talked about it in the last paper as well. It's part of the GP contract. I won't go into details because it will be here forever. An element of the GP contract that they get paid for. Premises, we've seen it. That's all right. Premises, we've seen an increase, which we've obviously talked about in past meetings around some of the pressures that we are seeing for prior years on rent reviews, etc. So obviously we've seen an increase on that. So we've got a variance on the premises. The other major area, I suppose, which goes in the opposite direction is on the primary care networks lines and the R's, which stands for additional role reimbursements. And we again talked about that last time and how we were seeing a slippage on that budget due to not that we haven't recruited enough people, it's just the recruitment that's come through has been at a lower scale, pay scale to the national toolkit was using. So you know, we've seen quite a significant surplus on that. And then the last sort of major pressure that's on there was the 263, which was a DP support fund, which again we talked about last time, which was the national incentive where we were funded slightly short of what was agreed, what was originally going to be funded, and so we actually topped that up. But you know, we're using some of our slippages within delegated primary care to top that up, so we can pay that out to DPs. And I think really that's all of the major areas covered. So if anyone's got any questions, or Mark wants to add anything, I'm not sure.
Anybody got any questions for Hannah? Any observations? No, good position for us to to be in. We're just asked to note the content of that report. So people happy with that? Yeah, that's smashing. So, because I'm conscious I'm running a bit behind as well. So the next item is item 8, and that is the COVID-19 vaccination programme. And that's, is it Becky? I've got Rebecca on the papers, but I can see you. So I think Becky's going to take us through that report.
Yeah, thank you very much. So I've been asked to attend today to provide a brief summary of the key steps to date in relation to the vaccination programme. The paper was brief, and I don't want that to be to distract the enormity of the task that has taken place over the last number of months, and particularly for our primary care networks and the wider teams that have played an instrumental role in that programme. Committee is just to ask to note the contents of the paper, and it is for information today. Primary Care Committee has received some brief updates throughout the programme. However, this paper is to attempt to try and draw all of that together from November until to date. So in terms of the programme starting off, that was around phase 1, cohorts 1 to 9. So that was adults up to the age of 50. And in November, NHS England asked practices to make urgent preparations to contribute to the vaccination programme in readiness for an enhanced service, which is a national contract published in order for practices to sign up to deliver that. So due to the logistics of that programme, practices working as primary care network groupings had to designate one site per primary care grouping, and that was to receive the vaccines and the consumables, because due to the scale of the programme, it just would not have been feasible at that time to roll it out to individual practices. So practices went through a designated site application programme, and the CCG reviewed those applications, and we made recommendations to NHS England for approval. And 13 sites which are listed in the paper were approved at that time. So then moving forward from that, NHS England published the final enhanced specification in December, and all 80 of our practices across TEES, which is 14 primary care networks, signed up. 2 of our networks worked together as one grouping, which was Holgate and Greater Middlesbrough, so that was 13 sites operating. And the groupings went live in waves, starting on the 14th of December, running through to the 11th of January. And again, that was due to the PCN's ability to respond, workforce, and also the vaccine supply at that time, which required sites to come online in a staged approach. Also during that time, 2 pharmacy sites were approved by NHS England to deliver vaccinations at Fairfield and Acklam. And again, that was to provide additional choice to patients of where they could receive their vaccination. And then moving forward in February and March, additional pharmacy sites were approved again by NHS England, and they were in Darlington, Skelton, Saltburn and Hartlepool, and patients could access the vaccine at those sites through the National Booking Service. And finally, during that time, 2 mass vaccination centres also went live across TEES. The first one was on the 1st of March, which was Darlington Arena, and then on the 22nd of March at the Riverside Stadium in Middlesbrough. Appendix 1 in the paper shows a map of all of our current vaccination sites, so you can visualise where they are right across Tees Valley. And during phase 1 of the programme, which I mentioned commencing in December, was covering cohorts 1 to 9, so all those people over 50, plus frontline health and social care workers. And Appendix 2 of the paper provides a summary of all of the key dates, so when those cohorts were announced. It has been further updated as cohorts 1 to 9 concluded on the 15th of April, when all adults in those cohorts had been offered a vaccine. And on the 13th of April, cohorts 10, which is ages at the moment 45 to 49, were opened up to vaccination through national booking and also primary care network sites. And just to give a very brief focus on the inequalities work to ensure that nobody's left behind. The CCG is also supporting primary care networks and the system to ensure those in the undeserved communities can access a vaccine. And what we've been supporting there with is a number of temporary sites that have been proposed and established to offer vaccines in alternative locations such as mosques, housing providers and also other community venues. And as I say, the CCG continues to support the PCNs in establishing those sites. So moving on to phase 2 of the programme, which is cohorts 10 to 12. And as I mentioned, currently cohorts 10, ages 45 to 49 is open to vaccination, but that is moving towards the completion of the 31st of July when all adults will have been offered a vaccination. So NHS England notified PCNs of an update to the contract in March, and PCNs wishing to opt in to provide vaccination to those cohorts had to submit an expression of interest. We went through an application process with those CCGs who were expressed an interest in delivering the vaccinations to gain assurance on the application and a number of criteria set by NHS England. And all of those expressions of interest were subsequently submitted to NHS England, and our PCNs were informed on the 31st of March if they had been approved to take forward the vaccination. Just very brief, in terms of data, we get a daily report from the region, which informs us how many vaccinations have been given at PCN and Tees Valley and regional level. And at Tees Valley level, as of the 18th of April, 364,871 vaccinations had been delivered, of which 83,585 of those were second doses. So just to summarise in terms of ongoing actions, all of the PCNs are continuing to deliver first and second doses to patients in cohorts 1 to 9. And those PCNs who opted to vaccinate cohorts 10 to 12 will be starting with those patients in 45 to 49. And when it's announced, they will be able to move into the cohorts 10, 11 and 12. We continue to prepare a weekly briefing report, which we submit to our PCNs and the system, and that gives an overview on a weekly basis of any key updates of guidance, policy, and any operational responses to the programme. We also continue to work very closely with our system partners to review any additional pharmacy applications. So as I mentioned, we have got a number of those sites already operating, but we also need to ensure that where PCNs have opted out of the vaccination of cohorts 10 to 12, that we look at alternative provision to ensure that there's choice for patients. We also continue to work with our local authorities to ensure that the work around the health inclusion continues at pace and to allow people to access a vaccine at a more suitable venue for them. And we also continue to support with the regional requests from the vaccination team to reduce burden on PCNs and make sure that we're not impacting on busy clinical and operational teams. So that's a very whistle-stop tour of what has been a very busy and challenging time. And I know lots on the call will be well versed in all of that, but I think it is quite important to be able to summarise where we've got to and probably the enormity of it. So I'm not sure if anyone's got any questions or queries or points of comment that they wanted to come in with. Thank you.
Yeah, I've got a few hands up at the top. I think I was delighted to see Vishali on the news with the temporary vaccination clinics in the mosques in Stockton and Middlesbrough. That was great to see. So well done in relation to that. But I think it does really get across the enormity of the challenge and how well that has been managed. If I can go to, I've got the two Davids and I've got Michelle. If I can go to David Emmerton first, please.
Thanks. I mean, firstly, I think it's been a really successful programme, so well done for everyone, and it's good the extra work that's been done for so-called hard to reach communities as well. I was just wondering, do we have a feel at this point what our take-up rate is for Tees Valley compared with the rest of the country? Is it sort of similar, better or worse, and are there any particular groupings or areas that we have concerns about?
In terms of the data, I do have the position from a northeast position, and I think we're running at about 85% vaccinated for cohorts 1 to 9. Regionally, that runs at about 86.5%, so we are in line with the regional position. There is sometimes a slight delay in information feeding through because it depends whether or not they've been vaccinated at mass vaccination pharmacy or PCNs. But I think we are at a similar position, certainly regionally to our other CCGs.
Thank you.
Brilliant. Thanks. David?
Yeah, thanks, Caroline. I think that's been a really, really good synopsis of it. And it's done what's almost nigh impossible, Becky, which is actually do justice to, and everybody knows what I mean when I say this, the really hard work to get from a standing start just before Christmas to mobilise at the scale and the pace that's been achieved not just by the PCNs, they've done a cracking job, not just by the CCG team, because you've done a cracking job as well, but actually by all partners involved. And you mentioned the mosques. The whole community's really risen to the challenge here. So it's something I think we should look back on when we get out of COVID completely and be really proud of. But what a fantastic effort by everybody. And I know it's been challenging because of the speed of it, and it's been literally made up as it went along, which caused all sorts of challenges and implications. But actually, everybody's just risen to that challenge and got on with it. So fantastic job and a really good synopsis of it in that report. Thank you.
Brilliant. Michelle?
I really just want to echo both David's comments. Well done, everybody. I also like the map as well. That's really useful and really understandable. I'm a very visual person and it looks great. So I'm thinking sort of public facing as well. That might be a good thing to use. But I've just got a quick query. And with the mosques, are those open, the vaccinations there, are they open to people who live and also attend the mosques? Or is it also open to people who travel from elsewhere but attend the mosques? Because I know that in Darlington, there are people who will travel to Middlesbrough to those venues. And I'm just wondering if we've got any data, because in Darlington, I know that the take-up has been a little bit slower.
Janet, do you want me to answer this, or do you want to come in at that point?
If you're happy, I can come in here, and I can say that the approach taken at the mosque was that, understandably, the communities with which where the mosques are sat within, yes, there are neighbourhoods that maybe don't attend the mosque. That wouldn't be their faith venue, but yes, they were vaccinated in the mosque setting because they came along with their neighbours who, you know, were members of the mosque faith group. So yes, they would be incorporated. Also, we are aware that people will have travelled from out with where that mosque location site was, because that's the mosque that they attend. But yes, from our point of view, they were eligible. So yes, they received the vaccine. If it was a way of tackling vaccine confidence and making sure that, yes, you know, we overcame hesitancy and got the messages across, then it was appropriate for us to do that. Certainly the approaches taken within the mosque vaccinations were that you can't exclude, you had to be inclusive, and making sure that if patients were in the eligible criteria, then yes, if they came forward at taking up that offer of vaccine, then it was appropriate to make sure that you did that. And there are a variety of approaches across how you tackle the vaccine hesitancy issues and how you support individuals to be able to feel that the time was right for them to accept the vaccine. That's going to continue. This is going to be on for months, because it does take quite some time for some people to be able to have the confidence to actually come forward and accept that vaccine. It's not a one-off offer. It needs to be repeated in a variety of different venues and settings that give people a chance to actually be able to then come forward and take up the vaccine. And I can be very rude, Caroline, and sneak in my next point now, if that's all right, because the uptake rates we've had for COVID vaccination is greater than we've achieved for other vaccination campaigns. So it's how we learn from this and how we expand it into helping patients to come forward with flu vaccination. And indeed, across the Tees Valley, some of our uptake rates for other vaccination programmes, especially some of the childhood immunisations, hasn't been as high as other areas in the country. And it's how we learn from how you do things differently and how you help support people to actually come forward for vaccination. So a lot of learning is going on behind the scenes to make sure that we use what we've learned in other vaccine programmes as well.
Brilliant. Thanks for that, Janet. That's really good to hear. And Robert, I can see you've got your hand up.
Yes, I just wanted to ask if the CCG is getting any advance guidance about the rollout of the boosters, which the government is talking about starting perhaps in September, and how that's going to be done. Will that be done through PCNs, or will that be done through national vaccination centres? And are you hearing anything about it yet? Or because it's only 5 months, September's only 5 months away, and time goes very fast, does it not?
Janet, are you able to answer that? Yeah.
Well, I can give you an update, but I can't answer the questions that we all want to know. We all want to know what, when, and I can't give answers to either of those two things as yet. However, what I can assure you, the members of the committee, about is that we are involved in those discussions and will continue to be so, to make sure that, yes, this fast-moving pace of the campaign that's happened up to this point continues to be able to develop and evolve in a way that allows us as and when we are administering boosters, to be able to do so in a way that helps to support the population of Tees Valley to come forward for those vaccinations as well. There is no more information I am able to share at the moment, but when we are able to do so, obviously we will do that.
Smashing. We okay with that? Yeah. That's great. So that was a smashing report, that, Becky. Thanks very much for taking us through that. And the ask is simply that we do note the contents of that report. So I presume everybody's happy with that. If we can move on then to the next item, which is the primary care national requirements, and Emma's going to take us through that. And we're up to page 42 now. Oh, am I right with that? Yeah. Primary. Yeah.
It's a presentation, Chair. James, putting it up now.
I was looking, thinking that's a digital update. Sorry. Yeah, Emma's going to take us through a presentation.
So, Jane, I think we've got 2 slides up. I'm not sure whether it can.
There we go. Lovely.
Okay. Thank you, Chair, and thank you to Jane. She's going to allow me to do my Professor Chris Whitty impression and do the next slide, please, throughout this, just so that I can facilitate my notes. We thought it was worth providing committee just a brief overview, and this is going to be brief, just a very high-level overview of some of the national requirements that have come into general practice over the last 12 months. So on the next slide, I've provided the hyperlink, and we can provide the presentation to members of the committee after the meeting if they would find it useful. The main source of information that's come from primary care has been through the NHS England website, and they've set up a specific coronavirus primary care source of hub of information, which includes things like bulletins, standard operating procedures, published letters, guidance. There's a whole raft of information on there. One of the main areas that we've been focusing on the next slide is around the standard operating procedure, which was first published on the 19th of March. And this just shows how frequently this is updated, because the current version is now no longer 4.1 on the 3rd of March. When I pulled this presentation together, we're now on version 4.2, which was published on April. This standard operating procedure covers many areas and changes quite fluidly, things like infection prevention and control, through to which covers things from personal protective equipment to decontamination of clinical rooms, moving through into staff testing when the lateral flow testing came on board, the operating model, which initially was around outbreak management, total triage, how practices could configure their sites to allow for face-to-face appointments and home visits, how they should manage patients who had COVID in terms of onward referrals, the interface that practices needed to have with 111, moving into long COVID requirements, clinical extremely vulnerable patients and how to maintain shielding, what to do with patients in care homes, how to make reasonable adjustments for patients, how to maintain patient registrations, a whole heap of information that changes quite frequently. In terms of what the CCG has done to support practices with the standard operating procedure, as well as publish our weekly, we started off as daily and has now moved on to weekly primary care bulletins, seeked assurance to this standard operating procedure back in April 2020 to make sure that practices were adhering to this standard operating procedure. And again in October 2020, as part of the emergency preparedness and resilience response, we reassessed practices' business continuity plans against this SOP to make sure that they were able to cope with potential surges and winter pressures and increased demands. To give you a flavour of the requirements that practices needed to do around clinically extremely vulnerable patients, on the next slide there's just a few bullet points in terms of the fluidity of requests that practices had to do in terms of adding patients onto the shielding list back in March, which I think then got revoked to say that practices didn't then need to do that after they'd undertaken that exercise. They had to, throughout this pandemic and still now, have to review all of the care plans attached to these people that are put on the clinically extremely vulnerable list, adapting them where appropriate, following up, making sure that they had medication supplies at the time when they were shielding, to make sure that there was people, or the NHS volunteer responders were able to get those medications to those patients. And then most recently in February, as part of the vaccination programme, a whole other raft of patients were added onto that special patient list, which is what the SPL is on there, the shielding patient list. So that's just a flavour of, and that's just one area within the SOP that practices had to respond to. On the next slide, the next couple of slides, are the key operational updates that have been received throughout the pandemic. So back in March, there was the move to the total triage system, where all practices were required to move to a telephone triage to then offer video consultation and online consultation. The CCG facilitated practices to do that through providing IT kit. There was some regional procurement around online consultation, and the CCG had 100% of our practices using total triage by the end of April. Nationally, things were freed up, which we've mentioned in previous item agendas on committee today, around QOF, Quality and Outcomes Framework, the Directed Enhanced Services, patient participation groups and friends and family tests, things like that were stood down. The CCG also stood down the local improvement scheme, which was mentioned in an earlier paper. So we've tried, as a CCG, we've moved with the national requirements as well. In April, all practices were required to open on bank holiday, so both Good Friday and Easter bank holiday Monday, increased their 111 slots. They also then had to report to the Directory of Service capacity reporting, which the CCGs facilitated through rolling out the Urgent Care Radar app that we have in place for secondary care. We've now rolled that out again to 100% of practices in Tees Valley who report their operational pressure escalation levels through this app, which mirrors the DOS capacity reporting requirements. In May, there was an additional support required to care homes. In June, they had to undertake staff risk assessments, in particular for the Black, Asian, minority ethnic group. That is now updated in the SOP that has just been updated as of the 12th of April, that practices are now required from the 1st of April this year, 2021, to review those staff risk assessments. There was a national return associated to that, which the CCG had to facilitate with practices to make sure that all staff who needed a risk assessment had one done. In July then, when the pandemic slightly eased nationally, some services were reinstated, so therefore the CCG reinstated the local improvement scheme, continued the flexibility of the extended hours provision, and continued with the hot clinic provision. On the next slide, please, Jane. In September, QOF was revised. Many indicators were changed, some were stood down. There was some income protection on some of the indicators. There was new indicators. There was just a big change around QOF that practices had to contend with. In October, the new contract requirements were published. And that included things of the continued temporary arrangements that were made in legislation around the 111 slots, the electronic repeat dispensing, and not needing patient consent to allow the electronic repeat dispensing. There was things around workforce data list cleansing. To note though that the contract wasn't actually published by NHS England until December, so practices were kind of working through the SOP up until the point that the national contract was published. In November, obviously with the vaccination programme coming on board, there was a requirement for local flexibility to be offered to practices to allow them to prioritise their work around the vaccination programme, and the CCG again stood down elements of the local improvement scheme in Chapter 2 with income protection. And in January, in line with the national direction of standing back down services such as QOF and the Directed Enhanced Service, the CCG again stood down the local improvement scheme for Chapter 1. For Chapter 1 for Quarter 4. Next slide, please, Jane. The Supporting General Practice Fund, again, this is something that comes on, it came in quite short notice from NHS England in November with the allocation of funding. This funding was on it was a significant amount of funding, but it was conditional on 7 national areas that practices had to sign up to deliver. That was increasing GP numbers and capacity, supporting the COVID oximetry at home model, supporting patients with long COVID, continuing to support the clinically extremely vulnerable patients, continuing with the backlog of appointments and routine vaccinations and immunisations, to make significant progress on learning disability health checks, and the expectation there was that the CCG would reach a target of 67% by March, of which the CCG achieved 77% unofficial data. And then number 7 was to potentially use some of the funding to offer backfill for staff absences if that was needed to support capacity. This funding has then been a second allocation in March, again mirroring the 7 national priority areas for this delivery, plus an expectation that some of this capacity is directed at those practices who are involved in the cohorts 10 to 12 of the vaccination programme. Looking ahead then into 2021-22, the nationally services have been reinstated. QOF, the Quality Outcomes Framework, is back up, fully up and running. There's been new standard financial directions published, the new DES directions have been published. We are still awaiting the 21-22 GP contract, but locally the CCG, as we've heard in the previous paper that the NHS committee has just ratified, the LIS Chapter 1 remains paused, extended hours flexibility is still being applied, and the hot clinics are still being provided. So that's as we look ahead into Q1 of 21-22. And that's it as a higher level overview, if anybody does have any questions.
You're on mute, Caroline, sorry.
Thank you. Sorry about that. I was saying thank you for that. That's really helpful to see all of the journey travelled. I think that does sum that up really really nicely. Has anybody got any questions? I've got Karen with a hand up.
Thanks, Caroline. Can you hear me? I'm just checking.
Yes.
Yeah. I'm dead really nervous now that nobody can hear me and I'm talking away. We thought it was really important to bring committee today an overview of the national requirements as to what's gone and what's expected, because that will help in terms of that cycle of sharing with committee the contract update reports and also any new requirements that need to be delivered by primary care, so that committee were cited on what their expectations were as we move forward. So just thought I'd advise why you were receiving that this year.
No, that it is. It's really helpful. Has anybody got any other questions or observations for Emma? No. Okay. Well, it's just for us to note that report. So thank you very much for taking us through that. That has been really helpful. The next item on our agenda is item 10, and this is a digital update report, and we're up to page 42. Graham's going to take us through that report. So over to you, Graham.
Great, thank you, Caroline. Yeah, I'm going to give a bit of an update from a digital point of view as to what we've achieved over this last year. So the report, the committee is asked to note the content of the report and to note and discuss the ongoing digital workload and to support the next steps for the digital work, which is mainly including the maximising the benefits and the utilisation of the digital solutions that have been rolled out within this year. So I'll try and give a high level view. As a digital team within the CCG, it's myself and it was Joanne Gaffney, who has since been successful in a national position. So she's moved on, but she was key to what we did in 2021. We now have a lady called Nikki Gibson supporting us in the team. So we've been implementing the digital strategy across the 80 practices across Tees Valley and supporting the 14 PCNs in the Tees Valley area. And the main objective in the year was to implement and embed online consultations, video consultations, SMS messaging services, and to increase the uptake of patient online services within primary care. And the COVID pandemic has had both a significant impact from a positive point of view as much as a negative point of view. And mainly that came from the necessity for GP practices to use the digital solutions to enable them to continue to provide services to patients. And so I think it moved our achievement of the digital strategy possibly on 2 years further down the line with some of the solutions that have been rolled out in such a short space of time. And based on that, we're now across the Tees Valley in a position where every patient or every citizen would have access to online consultations within their GP practice. Video consultations are also available across all GP practices, although it's most probably at the request of the clinician as to when the best time is to utilize those solutions. But we've also, another great achievement that we had in this year is the further implementation of the Great North Care Record. And there's something connected to that which backs it up, and I don't want to go too technical, but we have the Health Information Exchange, which is a central sort of portal which enables sharing information between all different trusts and different systems, so it means that they don't have to be on the same system, and we've increased the rollout of that across this year. So over this last year, we have rolled out a lot of digital solutions within primary care, and the drive and the next steps is to really progress with the uptake and the utilization of those solutions, but also mindful of the digital inclusion agenda and ensuring that they're available to some people, because sometimes the utilization potentially isn't as high because potentially it's not accessible. So that's one thing that we really need to focus on going forward. So that's a sort of high level summary. I'll just quickly go through some of the solutions that we've rolled out. I mentioned the Great North Care Record. We've now ensured that all 80 practices across Tees Valley are signed up and alive with the Great North Care Record. So that means that they're able to view information and also feed information into the Great North Care Record. We're working with the trusts within our area. North Tees and Hartlepool Foundation Trust are able to view information and have also just started feeding information into the system, which then means there's certain parts of a patient's record that's available in primary care to be able to view. So it's a two-way flow of information. South Tees are a little bit behind just due to their digital maturity, but we're working with them and supporting them into how they can enable to be able to view the information, I think, which is the first important step, but then also to be able to feed further information into the system. So where I've mentioned that we've got practices set up and 100% coverage from a clinical data flow, the next steps that we're looking at is around social care data to be able to flow between both health and social care being able to feed and view information. We've sent out, it mentions the 90% achievement around the data flow sign up. That was us getting ready and in preparation for when social care have access to the Great North Care Record and the Health Information Exchange. They aren't there yet. That's something that we're working with all the local authorities on to take that forward. And so that's the next steps with regards to the Great North Care Record. From an online consultations point of view, I mentioned that all practices are live, and some of them were across South Tees, especially it was March sort of time that we were progressing that with them. So it was a rapid implementation for them to get that in place and have that available for patients to access. We do have a wide range in the use, and I shared a little bit of the data which shows a range from 0.84 per thousand patient list size up to 248 per thousand list size, and some of that is down to potentially the demographic of the practice. Some of it's about the acceptance in the practice as to how it's been advertised and shared with patients for accessibility, and that's one of the key things that we want to progress going forward, working with working with practices, but also with the population as to when is the right time for being able to utilize these type of systems, so that we can reduce the variation that we've got in the range of uptake. We've gone from where it was something new to actually it's been used quite a lot, and I've had some practices that have requested possibly to turn it off on a weekend when they're not open, because they're coming into an increased workload over the weekend. But we're working with them to support how they can manage that flow coming through, because from an online point of view, the 24/7 nature of it is mostly what benefits patients and enables them to access services. So we need to find a way that we can make that work without creating an increased demand on the capacity that's available in primary care. Video consultations. I'd say this was one that has really taken off in this last year, and was one that we possibly would have taken quite a lot longer to get it in place within practices for clinicians to be able to see the benefit of utilising this solution. But from a necessity point of view, where patients have possibly felt that they possibly didn't want to attend GP practices, that this has created a solution. And so the uptake and the use of this in the first phases, so around about April, May sort of time, was a really high usage. And then as practices started to open up a little bit, we saw it drop back down again. So we really and there's a range from both patients and clinicians in the actual use of this, of when it feels appropriate for them. Some patients said it was fantastic for when they couldn't get into GP practices, but now they can get back in. Actually, they'd rather see a GP face to face. And from clinicians' point of view, some were like, it's fantastic, it's a great way of being able to get the access. And others, possibly, if they wanted to work in a call centre, they might have worked for EE sort of comments. So we really need to draw out where the benefits lie from both sides of that, and also, as previously mentioned, looking at and ensuring that it's accessible to all and inclusive to all. And that's what we'll be really focusing on in this next year. The remote working solutions, GP practices are normally quite a fixed estate from an IT point of view, that they have PCs within the consulting rooms and have quite fixed solutions. So laptops weren't really there wasn't many across the area. But as people were having to self-isolate and we're needing to work from home, we rolled out a considerable amount of laptops across the region. And within Tees Valley, we managed to get about over 500 laptops available into the practices, and we had to prioritize how we rolled them out, ensuring that they were available to clinicians initially, to ensure that they were able to provide services to patients from that point of view. But then as we come forward and as they come back in, it's going to be understanding and maximizing where that benefit lies, and how GP practices want to work going forward as to what the new normal is going to be. Because sometimes when you take a laptop or a PC out of a consulting room, if somebody else coming in doesn't have the laptop, they've then not got the access to the IT infrastructure. So we really need to understand that and ensure that we're able to support the practices to work going forward. I was just trying to pick out some of the highlights, conscious of time, but the rest of the paper goes into some of the other big pieces of work that we've carried out across the practices. And it was really just to focus some of the achievements we've done, working with the care homes to support them, to ensure that they were able to access the likes of Teams, to have multidisciplinary team meetings, and we're continuing to support the care homes as to having access to NHS mail, because I think that was one thing that was highlighted from a digital point of view, that they possibly weren't as included as they need to be as a partner. So we're supporting that going forward. Office 365 is something that we've had to roll out at scale, because the Office 2010 product was no longer supported by Microsoft from October 2020. So we've had to roll that out across all of the GP practices, and and ensuring that everybody is able to continue to use the solutions, because it's a change of model from where they would have a product sitting on the computer system to actually 365 is a subscription model. So it was ensuring that other partners that come in, sometimes the voluntary sector services that might come in and utilise the PCs within GP practices, that ensuring they still have access to those products and solutions. So that's one. We were hoping for that to be complete by the end of March this year, but due to the COVID impact, that has rolled on a little bit. We have got all practices booked in to do the transfer across, and that should hopefully be complete over the definitely by the end of May, but hopefully over the next 3 to 4 weeks. The COVID vaccination sites, as we mentioned, they're helping the primary care network sites get set up, ensuring that they had all of the excuse me, the equipment to be able to access the systems. Sometimes they were within practice sites, sometimes they were in non-NHS sites, so we had to get brand new broadband secure connection lines put in place or set up remote Wi-Fi access to ensure that they could access records. So that was something that meant we had to be really flexible in what it was that we were trying to deliver and ensure that we could support that. Some of the other bits that we just mentioned there are other smaller pieces of work, but it's just a sort of acknowledgement that sometimes some of the pieces of work that were coming out would look like we were just the 111 direct booking. We were looking at trying to support practices in profiling their appointments, but all of a sudden it's 46 practices that we need to support to do that. So it does take considerable amount of time to be able to support them with that. So it was just to give a real good flavour as to what we've achieved over this last year, and the flexibility that we've had to show to be able to ensure that that practices were able to continue to provide services to patients, and patients felt that they could still access them. So from a next steps point of view, as I've mentioned, as I've gone through, we've rolled out so much within this year, and we've put a heck of a lot onto practices to take these up in such a short space of time, but also from a patient's point of view as to what was available to them. So within this next year, we really want to embed that and to understand it, and to increase the utilisation where it's appropriate, and to also understand, any sort of limitations to being able to access some of the digital solutions that we make sure they're available. The other bit we've had to focus on to go into the next year is ensuring that we're able to continue the procurement of the solutions. So things like the video consultations was a national contract that was offered up, but then as a CCG we now have to pick that up going forward, and it's ensuring that we have the right products that have the right functionality from both a practice and a patient point of view. So they're the key things that we need to focus on, but also recognizing we still need to have that flexibility, so should something change as we go through the year, but also the products are changing, where one was offering online consultations might also now be offering video consultations, SMS, and they're all changing so rapidly and so quickly. It's supporting the practices to ensure that they've got the right products and the right functionality available to them to be able to provide the support to patients going forward. So that was a quick whistle stop through that paper, but I'm happy to answer any questions.
Brilliant. Thanks very much, Graham, for taking us through that. I really enjoyed reading that report. I completely agree with you in terms of it's obviously accelerated the agenda and got some of these things up and running much quicker than they might have otherwise happened. And it's so important, I think, picking up on Janet's point, that we don't that we do learn from some of the things that we've been able to achieve during this period, and make sure that we don't abandon them as soon as everything does go back to normal. So I've got a few hands up there. I'm conscious of time, but I think most people are going into the meeting afterwards. If I go with Janice first, then Michelle, and then Robert. So over to you, Janice.
Thank you. I will be really quick. It's just like CCG, we've been doing some work with practices around the pandemic and the positives, learnings, what we want to take forward. And one of the things that came back from practices was to commend Graham on all the work that he's done. And one of the things that practices have said they would like to see is a bit greater support for Graham going forward and the digital team strengthened going forward. I think there was a bit of concern around, as he's already said, procurement, keeping up with pace with everything and all of those things that need to happen. And because things happened at pace, like I say, I think it is credit to, and I'm singling Graham out as the name that I think just about everybody called if they had any IT issues. I think he got the lot. So it was to say thank you for that. I think also we welcome the user groups, and I think it's really important to get those user groups up and running from a practice and a patient perspective. There has been so many changes, and it's what is actually going to give greater benefit to practices and patients, but is sustainable and manages expectations, because we are in because of the quick response this time round, there's an expectation that practices are there, will respond and everything's and will send a message and we expect a message to be pinged back. So it's just how we manage the expectations in safe care in a sustainable way. And I think that starts with the user groups, but also strengthening that digital team if we can.
Brilliant. Yeah. Thanks for that, Janice. Michelle?
Just a quick one, Graham. First of all, you mentioned the Great North Care Record and the Health Information Exchange. And you mentioned South Tees that haven't, well, they're a little bit behind with sign up, and also social care as well. Have you got any timelines for that, bearing in mind, you know, the integrated care system, the digital strategy? How does all that fit in?
Yeah, so it's not that South Tees haven't signed up, it's the functionality to enable them to do that. So they don't have one EPR, electronic patient record system like North Tees do. They've got several systems, and they're working towards trying to get an EPR system in place which will enable them to be able to join into the Great North Care Record. Some of that is reliant upon funding and availability for them, so we're working with them and supporting the and in the meantime, they've actually invested into what they're calling a wraparound system, which will be a version of the Health Information Exchange for them as a trust, which will enable them to be able to feed in. So we're hoping they're in the midst of the rollout of that over this next 12 months, which then should start to mean that they're able to feed into the likes of the Health Information Exchange going forward. From a local authority and social care point of view, some of across the whole of the Great North Care Record, Sunderland City Council and Newcastle City Council are sort of pilot sites for enabling this, to understand the benefits that can be achieved from being part of the system, but also for the connectivity of the systems into it, because the different social care solutions, which we have a range of across our 5 local authorities. So we're keeping a close eye from the benefit of how the pilots are running to be able to jump on the back of that within our localities to be able to take that forward. I think we're looking at possibly over the next 2 years, most probably, before we start to see the benefits across social care.
Okay, and then just the second thing, and it's just declaring an interest here with my involvement with Healthwatch Darlington, but they've just completed a digital exclusion project with the primary care network as well. And that was also including Healthwatch England. And Healthwatch England are going to be publishing their report at the end of May, but in the meantime, we have had permission to share our findings as well. So I'll make sure that you're copied into that. It's digital exclusion and inclusion. So, you know, I think you might find that quite interesting.
Yeah, definitely. I mean, we use inclusion, trying to be a bit more positive, but
yeah.
You're totally right from that point of view. And I'd love to be able to catch up with you, because I think it'd be great to feed that information into our ICP digital work stream that we have, because I think it'd be invaluable in there. So I'll catch up with you outside of this, if that's okay, Michelle.
All right, then. Thank you.
Thank you.
Brilliant. Thanks, Robert.
Yes, what I'd like to ask, and I think this is probably more aimed at the clinicians than for Graham, is what training has been available to clinicians to enable them to work in a different way. I mean, where in other disciplines, for example, in psychotherapy, where therapy has been going on remotely, that they have made training courses available which have an accreditation to enable people to learn how to work differently, because it is a different skill set. I've done it myself. I was a GP until nearly 10 years ago, and I used to do an awful lot of telephone triage at the time. And it is a different skill set from seeing patients in the surgery and hands-on.
So from our we have been able to access something called the Digital First Primary Care funding, which is looking at how we can increase the uptake of digital solutions. And some of that has been around accessing the funding across primary care networks to look at developing digital champions within the primary care networks to enable the uniformity of using some of the solutions, but also identifying where we've got the gaps. I know within our digital transformation workstream, when we've worked across other colleagues in trusts as well, that they're saying, you know, sometimes some of the simpler bits of training of using systems, being able to touch type and things like that can really draw out the benefits and speed of use of some of these digital solutions. So we're looking at what the requirements are within the GP practices and across the primary care networks to help us to access some of those elements of training. But I'll let the other clinicians come in as well.
Janet and then Nick.
So suffice it to say that when you actually really have to, because it's the way you get to consult with your patients, it's surprising how quick you want to learn. That maybe you have to learn more quickly than you ever thought you were going to. I've done more video consultations than I would ever dreamt of wanting to do. When you've got to do it, you get on, and you'd be surprising how much you can learn on the job. But there's many tools that are available to clinicians to actually help support you as to how you adapt and adjust your consultation style to whichever media you're able to use. So there are supportive materials out there, absolutely, but on the job training, can't beat it in this circumstance.
Thanks, Janet. Nick?
Yeah, I mean, I'm a GP trainer, and so I've been involved in some of the sort of training the poor GP registrars how to do sort of video consultations, and there's been some little interesting nuances which sometimes I just pick them up by reading stuff that came through online, a bit like Janet, you know, because you need to know it, you sort of tend to read it. And one of them was sort of getting patients to consent and writing it down that they consented to have pictures put in their notes, you know, and sometimes I used to think it was a bit odd, but then, you know, you do get some quite amazing pictures that patients send you. So it's like, you know, I do it as a routine now, you know, and to teach people that it's just a bit like, you know, consent and everything, you know. So it's amazing what you learn. But yeah, a lot of it has been learning from colleagues about, I mean, I'm useless at sort of IT. So my big difficulty has been which button to press and what to do next. Is what I've learned most, as opposed to consulting patients particularly. Another interesting thing is asking permission for the video consult, because you won't believe how many women need to get changed and do the hair before they'll actually talk to you online. But there you go.
Thanks, Nick. Janice?
Difficulties. Yeah, just very quickly, the training, we have a training hub that is part of the ICP, so the Tees Valley CCG area, and as part of that we are looking at doing training needs analysis for all staff. So it's not just around GPs, but there's many other people who are increasing electronic consultations, nurses, etc. So it was just really to give some assurance that we are looking at all of these things, and we'll try and feed it and build it into the training hub and training plans going forward as well.
Brilliant. Thanks very much for that. So I'm very conscious that we're over time, but I wanted to do the report justice because obviously there's a lot of work gone into it. So well done, Graham. We're asked to note the content of the report. I think we've given it a good discussion and support the next steps. So I think everybody can agree to do that. Yeah, we've got lots of nods. So thank you very much. The next item's page 59, and that's our annual report I'm not going to go through it in any detail, but the gist of it is that we've met on 7 occasions. There's a long list of things that we've considered, and I think we can say that we've complied with our terms of reference. Is everybody happy for us to present that report back up to the governing body? Yeah.
Yes.
Yeah, lovely. Lots of nods there. There's no items for information. I haven't been informed of any items of any other business. So now it's over to questions or observations from members of the public. Nick, is there anything that you want to ask us or make comment on?
No, I'm fine, thanks. I mainly joined for some of the sort of COVID updates and everything that was in the sort of recovery and the vaccination presentations. That more than covered it, and yeah, it was really, really good to hear some good steps being taken.
Brilliant. Well, thank you so much for joining us. It's good to have members of the public come along to these meetings. So thank you for joining us, especially on a sunny afternoon. So the next item is any items that we need to report specifically on the risk register. I don't think that there is no. Karen's shaking her head, so I'm happy to go with that. And then obviously we'll do a summary from this meeting up to the governing body, and that'll be captured for when we next meet. So the date and time of the next meeting is the 15th of June on a Tuesday. So if I don't see you before, I'll see you at that. And then for people that need to go into the next meeting, we'll go straight over to Teams. Okay. Yeah. Thank you very much, folks. See you shortly.